Okay, so I'm going to present to you a very interesting case about valve-in-valve small anatomy. So it's about a female 84-year-old with gradually worsening effort dyspnea. She has undergone AVR with magna is 90 millimeter, and he has a history of PCI in circumflex right coronary artery and PDA, arterial hypertension, dyslipidemia, carotid artery disease, and baseline creatinine about 1.4. Elevated surgical risk scores. The magna is a standard valve with bovine pericardial leaflets, and it's fracturable. So the screening coro revealed coronary artery disease, no ISR in the circumflex, no ISR in proximal RCA, but we had to do a prevail drug coating balloon in ISR of PDA. The screening echo, the max velocity was about 4 millimeters per second, the LVOT 0.85, and preserved left ventricular fraction with elevated gradients. Here you can see the screening echo. So here you can see the screening coro and the relationship of the bioprosthetic biological valve with the ostia of the coronary artery. So you can see here the left coronary artery and the right one. And the disease in the PDA, we performed a drug-coated balloon prevail. So you can see here the measurements from the angiography. And here you can see some picture of the Allegra valve that we chose in order to perform the TAVI, the valve-in-valve. The coronary high, 12.9 and 15.8. Here you can see some pictures from magna is from the valve-in-valve application and the Allegra valve inside the magna is. The true ID is 17. Here you can see favorable femoral access for both femoral arteries. The heart valve team of our hospital decided that transcatheter heart valve implantation should be the optimal strategy, valve-in-valve with Allegra valve 23. Here you can see the procedural steps. Now I'm going to show you the video. Here you can, we start the puncture of the right radial artery. Echo-guided puncture of the right femoral artery. You can see some calcification here, mostly the posterior wall, near to the bifurcation. Here you can see the puncture. Right here. Feel free to make any comments whenever you want.
So that is the normal simplified approach that just saw before in our live case. So it's this typical approach.
The prostyle and the preparation of the Allegra valve.
It's a different kind of valve, rather mechanistic, I would say. Labra, do you have experience with this valve?
No, I haven't.
So does anyone tell you have experience with everything? Do you have with that?
We have got one case with Allegra.
Yeah.
There is a new concept. The valve concept is usually considered in valve-in-valve anatomy and small annulus.
Yes.
But we will see the long-term results, we don't know. The sizing issues are maybe discussable. There are some problems compared to the other type of valves. But it seems, especially with fracturable valves, also usage of Allegra in their study also with good results. But we had to wait the results, long-term results.
So do you think that it's a supraannular valve? So on paper, it's like self-expanding supraannular is sort of evolute. Do you think if the smart valve, if the smart trial would have been, would have done by with the Allegra instead of evolute, we would have the same results, or it's something with the function of the valve? Because we know in the pole of the valve, this is relatively, it's more physiologically functioning valve. Do you have any idea?
Fully agree with you. The advantage of these valves is the supraannular nature, especially in valve procedures. But the shape of the Allegra compared to Evolute is a little bit different, and the feeling that I was implanted compared to the Evolute, the feeling when you release the valve is also completely different with the Evolute.
It's more mechanistic, as you can see here. We just press the button, relatively easy to place it. Still, I think it's nice to pace.
Here's the button. Now we push the button.
And then you can appreciate on the right, the rapid deployment of the valve. And Professor will draw it later. We'll have a satellite symposium that's on this valve. But you can appreciate the radio pack markers. You can align them. And you can, yes? Costa.
I've just been to see it a few times in Milan, this valve. So if I'm right, it's a retrievable up to this point, is that right? Yes. So that's one of the advantages. And theoretically, I mean, this is not easy. It could be more easily aligned in terms of commissures. So these little points it has theoretically would help
yes.
you.
Maybe the opening is somewhat different, but we don't know. There's not much experience with this valve. I think it's a new valve. We were talking about hundreds implanted instead of thousands upon thousands like the Evolute. So it's a new valve for us. So it's an interesting technology, maybe a little bit older, but still has potential to be a proper valve, I think. So the idea here is mainly, of course, to place a self-expanding valve in a small valve and maybe optimize the result by cracking the valve. So, Femi, yes?
Are there any advantages for the small annulus of the Allegra valve?
Yes, supposedly it's designed for the small annuli.
Do you have experience?
No, we don't.
Adonis, I think, has put an Allegra valve.
It's a small study that it has to with Allegra in a small annuli, and I think this is the market area of this valve. It's in small annuli, maybe valve-in-valve procedures. Easy to do cracking inside it.
So just one question: did you fracture the valve before or after? You fractured before you put the TAV, isn't it?
No, we always do after the placement.
Because I've seen a sort of a balloon sort of there.
No, now we're placing the Atlas balloon.
Because I've seen a balloon before, but that wasn't. Do you do that? Do you do pre-dilatation to these biological valves?
Well, most of the times no, but in this situation we did because it was very, very stenosed, and yeah.
And do you put cerebral embolic devices when you do pre-dilatation?
Here, sorry, but here you can see the cracking of the valve, and you immediately feel for the ones that they haven't experienced, for the fellows, you immediately hear a sound, and this is an audible crack. So after that, we checked the hemodynamics, and I think they were good. So some of the operators are doing cracking before placing the valve. I think it's it's not very good in terms of stability of the patient. Sometimes patients get hemodynamically unstable. But here the result was good after cracking, and this is a good demonstration, I think, of the cracking with a valve in a small annuli. But to go back to the previous question, Femi, would you, geographically at least, and also in the CT, we saw that maybe it's this aortic annulus could accommodate a bigger than 19 valve. Would you do something different? So in this case, would you place a larger valve? Yeah, at the very beginning. So it's a very old valve. Didn't actually thrombosed, but the patient was not feeling good from day 2 after the operation. So it was
so
not.
The patient had a patient-prosthesis mismatch from the very beginning, right?
So it was not durability, but it was an issue of patient-prosthesis mismatch.
Yeah. So in retrospect, I think root augmentation should have been done in the first place.
Yeah. Okay. Costa, would you do something different in this case, in retrospect?
No, I think you're right. We discussed this morning. We hate 19 as a size. We do get a lot of small aortic annuli, and country to country there is a difference.
Yeah.
We're very much different to the British or the German on the Danish population, but when we know that the annulus is small, I mean, I don't know, I can't remember, what was her BSA? Do you know her size of the patient?
So the BSA...
The size of the patient, BSA or...
Height, weight.
You don't have it. Anyway, we always look at the size when we try to implant, and in theory, no man really would get a 19. And as we discussed before, doing a Manugian is not an extremely difficult operation, really. So you can get the extra size, which might have saved.
But do you get additional information by doing CT, or you just rely on what you see?
No, really, I think this is one of the day-to-day stories we need to change from the surgical point of view. We really need to get the information you guys get when you do this, because the more prepared we are, the better the outcome will be. We are used to operating, as I said, just by seeing an echo, but I think really, and sometimes also, just to return the comment, we get an echo that says annulus of 32, and they really mean the sinotubular junction or something else. So getting the detail helps a lot to plan ahead and do a good operation.
Okay, Nikos Pilias has a question, and then Theo.
Excellent case, step by step. Can you show again the measurements of the annulus on the CT? Because I find it for valve in valve, especially for very small surgical valves, what is the area? Let's see.
The area
but this is, I guess, this is, yeah, that's probably within the valve, because if 200 is...
It's very, very small. It's
like,
outside of every IFU.
It's a child's probably.
Yeah, so that's why it's one of the reasons that you can try something different. So it's very, very small.
Okay. Thanks a lot.
Thank you, Leah. I think we can proceed. And Dr. Kofidis, maybe. Yeah. Is the next speaker.
And now let's move.